Hi, my name is Monica Walker, and I am the Clinical Relations Manager at Michigan Opioid Prescribing Engagement Network, Michigan Open. Basically, what that means is that I am the liaison between Michigan Open's evidence-based findings and our partners. Additionally, I am a nurse by training, having spent much of my bedside nursing in the emergency department and more recently in surgical services. We're here today to talk about transitions of care. So our objectives are, one, to define transitions of care, also to discuss how a comprehensive transition of care model can effectively support safe patient care. We need to recognize the non-prescriber's role, and we need to be able to foster clear, consistent, non-stigmatizing pain management messaging with our patients. So when I think of transitions of care, I feel that it is very analogous to other modes of transportation and transit of much of our cargo throughout the U.S., where communication really is very key to keep all things moving in the right order. So similarly to this picture here, transitions of care is the movement of patients within one care setting to another. So in that space, I'd like to just very briefly touch upon a couple of studies that were done. So this study shows preoperative opioid use and associated outcomes after major abdominal surgery, where we can see that there's increased costs in the hospitalization, increased rate of complications, and increased rate of readmissions for these patients that had preoperative opioid use. Similarly, this study showed preoperative opioid exposure not only increased the rate at which patients would request opioid refills, but it also increased prolonged use. So although there will always be a small percentage that will go on to become new persistent opioid users, those that had prior opioid exposure really went into prolonged use at a far greater rate. This study shows post-operative care coordination among patients on chronic opioid therapy. And while about 90% of them, so the majority, truly had a usual prescriber, many are exposed to high-risk prescribing, which means having overlapping prescriptions, being co-prescribed benzodiazepines, having multiple prescribers. And ultimately, only approximately 30% ended up returning to their usual prescribers within 30 days. So while a great majority of the patients will go through a surgical procedure or any acute care episode and do well, we need to be aware that there will always be those percentage of people that may actually do worse. They're becoming a new chronic user, or they came in with that pre-operative opioid exposure and really have the surgery has not improved their state. So we need to be cognizant of this. Lastly, another study showed us risk factors for persistent opioid use. And that persistent opioid use means those patients that continue to use their opioids 3 to 6 months after their acute care episode. So basically using those opioids for reasons other than what the initial prescription was intended for. Prior substance use disorder and chronic pain diagnoses were the most predictive of prolonged opioid use. So collectively, these and other studies really highlight the need for screening of our patients prior to surgery and really having a consistent method or process to transfer those patients through their perioperative journey. So who prescribes for new persistent users? In this graph, we can see that the percentage of opioid prescriptions by specialty shows surgery immediately at surgery or afterwards is the primary prescriber of the opioids, whereas further downstream from the acute care episode, you will see primary care and other specialties are truly the ones that are prescribing the most opioids. We lack a systemic approach to identify and communicate that preoperative risk for pain and opioid-related outcomes. We also consistently are unable to tailor our perioperative pain management in ways such as encouraging opioid-sparing options or providing opioid antagonists for high-risk patients. And lastly, we do not consistently communicate that risk and coordinate our care across all specialties and all our providers. So when we stop and think that in this space there are greater than 10 million individuals who currently are on long-term opioid therapy, and if we also know that the average number of procedures over a lifetime per individual is 9.2 procedures, then what this amounts to is 90 million opportunities to uncoordinate care. So thinking back again on that very first picture of the transit system at the port, these are opportunities where we really need to be concise in our communication and coordinate the passage of that patient, the transitions of care. So at Michigan Open, we are in the process of creating a comprehensive care pathway that will identify these at-risk patients. We'll be able to consistently tailor perioperative pain management to these specific patient needs. We will be optimizing that transitions of care for the surgical patients. And an integral piece of that is that we will be educating not only the patients, but the providers. Within this comprehensive care pathway, communication is key. This includes not only accurate and detailed documentation, but verbal reports or handoffs. We need to speak from one consistent message within our teams and in what we relay to our patients. This communication will provide the safe and effective transfer of responsibility for the patient's care. Additionally, we need to educate our patients, ensuring that they comprehend their discharge instructions, and we truly need to empower them to seek answers to their questions, thereby enabling them to play an active role in their care and recovery. Provider education and empowerment is also important so that we can own our practice and keep up to date on the evidence-based findings. This MOOC is a great resource for that as well. And finally, a really crucial piece about communication. Stigma is recovery's greatest enemy. And we really need, within transitions of care, to foster clear, consistent, non-stigmatizing pain management messaging with patients. We need to use the words that matter. We need to use the words that allow the patients to feel safe in seeking and continuing their treatment. And it is imperative upon all of us when we interact with patients that we remember that this is not a moral failure but a brain disorder, and as such, patients can recover. I hope this presentation will be helpful to you in your practice, and please visit Michigan Open for additional resources for both patient and provider education. Thank you.